Welcome to Voices in Value-Based Care. I'm Matt Fusan. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. On this program, we explore stories from the field about how real organizations are dealing with this change. You can follow the show on Twitter at #VoicesInVBC and follow Azara Healthcare on Twitter at Azara DRVS. On the program today, I'm talking with Heather Budd, Executive Vice President of Clinical Transformation here at Azara Healthcare. Welcome to the show. It's great to have you.
Thank you so much, Matt. It's good to be here.
Before we jump in, take a few minutes and just tell us about yourself and your path to Azara Healthcare.
Sure. Happy to do that. So as Matt said, my name is Heather Budd, and my path is kind of to where I am today started at Dana-Farber Cancer Institute. I was actually placed at the front desk of the pediatric Jimmy Fund clinic there, and I kind of learned about healthcare and the systems and operations of healthcare from the ground up. It was a great way to understand both the patient experience as well as begin to learn about the importance of quality in care delivery, but also data, and also understand the provider caregiver experience as well. So give me a lot of insight into all those pieces. I later went on to work at a consulting firm in which I got to focus on data collection and meaning making, let's say creating reports and things like that, and ultimately solutions for primary care-based organizations and ultimately community health center organizations. And I fell in love with community health in that job and eventually took a role as the director of quality at a community health center in Rhode Island. And from there, as I kind of built my experience, I went on to become their COO, really fell in love with operations and got to do some really interesting, innovative care with their in partnership with one of the payers in the area, where we actually integrated payer data in such a way that we were able to see care gaps for members, the actual total cost for those members, and really start to show that we were bending the cost curve in the care that we were delivering. So there were some exciting things. I helped build out their care management program in coordination with our director of nursing. So a lot of interesting work along with transforming our care teams to really maximize the work that the support staff were doing, celebrate their roles, and unburden the providers as much as we could.
Excellent. And actually bending the cost curve and showing that, congratulations. There's always talk of it. It is much harder to do in practice, especially sometimes at a community health center where you don't have quite as many resources.
That's very true.
Start out, when we were prepping, we talked about, what kind of the first steps for an organization to get their arms around their value-based contract universe. And we use that term because a lot of organizations clearly are still getting majority of their revenue from fee-for-service. And the value-based contracts tend to be numerous and various, and understanding that landscape is important. Tell us kind of how to get started there.
Sure. In my estimation, and of course this will look different for different organizations, and that's the real key, is kind of understanding where you are in the arc of this journey. It's sort of safe to say that everyone is ultimately heading towards a value-based world. That seems pretty clear. However, many of us are still in this two-canoe situation where we're balancing one foot in the fee-for-service side and one foot in the value-based care side. And so as you look at, where the bulk of your revenue is coming from, that's kind of the thing you want to preserve, of course, and make sure you continue to execute on. But as we move in that direction towards value-based care, we want to make sure we are well positioned to have the data to make sure we're executing on the care the best we possibly can, prove, right, that we are
Mm-hmm.
delivering care at the excellent quality we know everyone is, and then be able to make good bets in what you want to make your gambles on, right, as you enter into some of these value-based care kinds of contracts. So that's kind of the assessment of the universe, understanding where you are in that platform, and then thinking about where you're headed, making sure you're prepared with great data to be able to continue to assess as you go along that stratum.
And we know one of the challenges that every value-based contract is set up a little bit different. There's overlaps, but there's variances. And even for the same measure, different contracts want to see different performance levels, and there's breakouts, and gets confusing pretty quickly. But once you have that universe defined, how do you move from there to tactical planning and execution, right? That's where the rubber meets the road. For sure.
Absolutely. Yeah. So to me, they're kind of two parallel paths here. The first is establishing trust in your data. If you don't have trust and credibility in your data from not just the management or administrative executive level, but also all the way down to the point of care level, you're kind of going to be dead in the water. And the reason is, if those two teams don't agree about what we're seeing in the numbers, it's very hard to move in the direction of improvement, right? So you got to invest in helping people understand, where is this data coming from, and how can I personally play a role in improving it or getting the support to do that, so that we all agree, yep, this is our data. And that's, of course, that usually involves some sort of data solution, a vendor that's helping you do that. In certain cases, it is a build on your own, depending on the kind of organization you are. But either way, you got to have really, really good integration and partnership there. The second piece is taking a look at the contracts that are before you. And you already started to talk about this, Matt, right? You might have the same measures in different contracts with different targets, right, for performance.
Yep.
What we see a lot of our clients doing, and I certainly did some of this in my own work at the health center, is looking to understand, where does it make sense to spend your energy, right? Where do you have the greatest number of patients that are going to be a fit for the denominators for some of the measures that you are being asked to be responsible for? And where do you actually have the data to do something about it? Because there are going to be contracts that will include measures you don't actually have control of the data or even access to in certain cases, although that's something we always want to be advocating for. That's kind of like a third path. If you don't have the data, make sure you're getting access to it as soon as you can, so that you're playing poker with a full set of cards.
Right.
But definitely just looking at all those measures and all the contracts together, figuring out where's the overlap, where's the best bang for your buck, because we only have limited time and energy, and actually focus, especially of our clinical care teams, who ultimately have to do the work at the end of the day.
And one of the challenges there is always the burnout factor, right? And how many things can we ask the care teams to be looking at the same time, on top of taking care of the patient, right? It's always thought of, well, we got to do these things, but it's on top of, quote unquote, the day job, right? Which can be a challenge.
Right. And I think that's why I'm such a believer in, truly transformative team-based care. I do not think it's realistic for us to ask providers to do all of the things that are part of these contracts. Is simply not. It doesn't mean that they can't be ultimately responsible for it. They can't actually do all of the pieces. And that is what I mean by really delegating the work of much of that away from the provider to talented support staff who can spend longer with the patient, who can, do all these screenings and things like that we're being asked to do, and are very important in terms of care, but may not require the level of medical skill that MDs, DOs, NPs, PAs, et cetera, have garnered in all their education.
We also talked about potentially impacting compensation.
Absolutely.
As an influencer or a motivator. Where do you see that coming out? I'd imagine that based on culture and structure and ownership of a group, right? All those come into play. Yep. Tell us a little bit about your thoughts about the comp being a motivator.
Sure. Well, as you already implied, and I completely agree, ownership model matters quite a bit here. If the providers that we're talking about own the practice, it's very easy. Doing well goes directly to their bottom line, right? So that's a much easier sell. Internally, the culture is going to be kind of built around some of those things. That's not the only thing. Most of us are in healthcare because we actually care about delivering care as well, but it's going to impact the way you see the world. If it is an environment like a community health center or an employed situation, you're going to have to do much more work to build that buy-in around why is this important? Why do we care about it? And how does it ultimately benefit both the patient and your personal bottom line? And I think that the trust in the data is, again, a foundational piece to that. If your teams don't trust the data, any incentive compensation plan that's tied to that, you can imagine, is going to be immediately in question, right? So you don't want to set up a scenario where they are coming back and saying, well, I don't agree,
Right.
So you want to handle that first and foremost. And I think you want to be starting that step as a longer path and hopefully you've explained to them, this is actually where we're heading, so that you're cultivating that buy-in in this process all the way through. Here's why we're asking you to spend some time understanding this piece now. We are moving towards this kind of management where we're going to be sending reports to you on kind of cadence, and also sharing results across the team with a great degree of transparency so that you can all learn from each other, creating and cultivating a learning environment rather than anything that sounds or feels punitive. And then sort of progressing from there to, let's take a combination, especially if you're still in a fee-for-service based environment, right? So again, right sizing this to what your current model is in terms of the contracts versus fee-for-service. Still need to have some productivity goals, right? If we still have one of those feet in that canoe, and then moving in the direction of starting to choose some metrics that matter or fit with the area of practice that the provider is practicing in. Family practice is obviously going to run the gamut. If they are only doing pediatrics, you got to make sure you've got some measures that fit for them, et cetera. So that's fairly straightforward and obvious. The next piece that I would say goes right along with that is ensuring that you build in a plan to compensate the whole team. If we're going to be asking that care team, the support staff, who honestly are heroes of our healthcare system in a lot of ways, I have a ton of real care for those workers, and they often don't get the recognition that I think they deserve. We need to be sure that we are building these bonuses or incentive comp plans into their salaries as well, so that we can recognize the work they're doing and properly incent them to want to do a better job, right? We can't just be relying on their goodwill, even though they are wonderful people who are there to do the right thing.
And I think that's really critical, to date, and not saying that others haven't been thinking or talking, but generally you hear about provider comp planned, right? And incentives, et cetera. But I couldn't agree more. And you might get more bang for your buck on those incentives at the care team just because of the realities of the economics, right? So
exactly,
building out that model that includes everybody is, I think, really the critical step. And you could even potentially start, just call it bottom up, just, from not the best term to use probably, but start the incentive model without directly at the provider level first, right? And kind of work out the kinks and get the team excited about it, and then bring along the providers, as opposed to the top-down model, providers first, and then drag everybody with them.
Yeah, exactly. And I think the one other thing I would add to it, and agree with everything you said there, is, as you begin to add in the layer of those measures that really are, it's usually a combination of process and true performance measures, right? As you begin to layer that in, once you're starting to win real performance dollars from whatever the contracts you may have, usually that works where you're winning as a team. Sometimes it's by provider. And so, of course, that's a little bit different. But part of the goal here, too, is to get your team of providers to operate as a team that supports each other. And when they win together, they all win more. right? So
Right.
everybody sort of wins together. And one of the reasons why I'm making this particular point is that one of the objections I commonly hear when I am working with teams around visit planning, for example, is they'll say, well, this isn't my patient. And my response to that is, but it's the organization's patient, and they have some care gaps, and they're here today, which means that this is your best shot
Right.
at closing that care gap, whatever it may be. So even though you don't have sort of technical ownership over them, the goal is that we as a team are taking care of this patient. So don't kick that can down the lane, because it's going to bite you in the end.
That's a great point. Elevating to organization level and what's best for the patient, regardless of assigned to me or not. Right.
Exactly. So well said. Yeah.
As we continue to talk about team-based care, what type of support systems or resources are needed to be considered, for VBC type of arrangements and models? We've talked about the team, but we haven't really drilled into what that team's made up of. And I would assume this varies depending on the models, but tell us your thoughts on kind of team makeup.
Yeah. So if we start at the care delivery team, and then we'll kind of work our way up from there a little bit, I think you want to have ideally a ratio of 1.5 support staff per provider at a minimum. And the reason I say that is that you need to build in the time to do the care planning and the execution of that care, which means that if I'm rooming a patient, the provider can be seeing someone, and then there's another patient that's in the wings that I'm doing the next thing for. And I don't have to be just one-to-one, where we get into this sort of chain of not having enough to kind of do the right thing. So that's what I mean by kind of setting yourself up for success with the support staff. So that seems important. Then from there, we start to want to build into what are what I call ancillary support staff, who can, again, augment the provider in terms of education for the patient. So that might be a diabetic educator, a nutritionist, a pharmacist who can teach patients how to take their meds, that kind of level. And those can include community health workers who might address social determinants of health, which, depending on the kinds of patients that you are working with, can be a huge barrier to care and really essential for us to actually move the needle. Despite everyone's best efforts, if I can't pay for my medicine, it's probably not going to improve my numbers, right?
Right.
And then from there, we start to graduate into more complex care coordination, as I like to call it. And we call these roles all sorts of things across the healthcare kind of continuum. Typically, you're going to hear this called a care coordinator or a care manager, maybe a case manager, depending on where they're staffed from.
That's right.
And of course, we tend to see trust levels in these staff being much higher when they're employed by the practice itself rather than the payer, even though sometimes payers have a generous approach to this and are very well-meaning in trying to help offer these support staff. So those are kind of the classic staff that you want to see in an environment like this. Now, moving from there, in order to really do well executed job on how do we actually manage all of these different payer contracts, I think there's a whole new role that in certain cases does exist in practices now, but if it doesn't yet, it needs to. And that is essentially the payer contract manager, coordinator, director. It doesn't matter what the sort of level is, but that person needs to be managing the relationships in many cases with the various payers in the payer mix, and looking at all those contracts in a holistic way, and doing the ongoing work that I talked about in the beginning of saying, okay, which contracts are worth our time and effort and energy, and how are we doing so that once we get to the moment when the payer says, hey, here's how much we're going to pay you, we are not surprised in the least. We know exactly what to expect. We are planning for it. And so if we're going to be making money, that's great. We already know what we're planning to do with those dollars. If we are going to lose money, we have a plan to make up for that. Because that can be really painful if you are in some sort of risk-based contract where, that money really is at risk or potentially even being clawed back, the most painful of such contracts.
Absolutely. And that's a unique skill set that I don't know that we've really figured out, right? Because as you mentioned, you're going to want some level of clinical understanding. You're going to want some level of how the operations on the ground with the care teams work, some level of analytics to pull the stuff together, some financial aspects, right? So I agree and think that that role will continue to evolve and define, right? It's so new. And
Yeah.
I think most organizations that I've talked to and we've talked to kind of just is who's available, not in a negative way, but it's not necessarily the right fit. It's we need somebody to do this type of role.
Yes.
So that'll be exciting to see, as well as, what's going to come down the line from a software product tool perspective that helps with that. Most of the people that I've had discussions with, generally people are still doing it on spreadsheets.
Absolutely.
And it is painful for sure.
Yeah. Well, and may I add just a few additional things to that? So I think absolutely right. These are still being defined. And I would add that this person, this role, ideally should have some staff under them as well. Absolutely.
This isn't a one-person job.
No. What I envision this role doing in addition to this is, we haven't really mentioned the word attribution yet, but it's a key part of this, right? So Of course, payer data usually breaks down into who are the attributed or enrolled patients in a payer versus, the care gaps and cost data and things like that. Very reductive breakdown there, but can do the job for us at the moment, right? So when we think about attribution and enrollment, there's usually patients that we have seen and we agree they are our patients and we call them our patients. And then there are going to be members who are attributed to us by our payer, but we have not had the opportunity, let's call it, to see yet. And so to me, this is a huge outreach opportunity. And this is not a clinical role in the least. We can just be cold calling these patients, perhaps using text messaging to, reach out to these patients to hopefully matriculate them into our environment. Let's get them in. There are contracts out there that I have seen which just simply incent a practice to see the patient once per year. So the dollar value of just getting them over your threshold is huge.
Yes.
And so it's worth it to pay someone to do this work. And it's definitely not appropriate to use someone with clinical expertise to do this.
Agreed. You're not getting your bang for your buck on that one, right?
Exactly. Yeah.
Different practices I've worked with leverage their front desk and office staff, right? Where we're going to bake in an hour a day where this is what you do. And I've seen some success there for sure. But like you said, you want to really make sure those activities are at the right license or non-license level, right? When we're always talking top of license type of work.
Exactly. And there will be some of those patients who do require that clinical resource. And that's when you escalate, right? Like, okay, if you can see a patient who, if you happen to have access to cost data, for example, which is the holy grail, right? You can see a patient that's attributed to you and is costing a lot of money and hasn't hit the reinsurance point. That's going to be very valuable to you to bring those folks in your door and help them use the system much more appropriately. How can you get them out of the emergency room to be receiving their care, or prevent those readmits, et cetera, which is the obvious low-hanging fruit in that environment.
I'm going to ask you a big question, but I'm also going to warn you, we only have about 3 minutes left, a little bit more. But social determinants of health we touched on. We haven't mentioned anything behavioral health. Dental health, I know, is big in the FQHC delivery model. Do we think that the commercial world's going to start incorporating these things more into the models, in the value-based care models, ultimately because they have better patient outcomes, and better patient outcomes generally lead to lower cost?
I mean, I believe they will have to, in order to really move the needle. So again, it's all about where you are on that arc. Mm-hmm. And if you are much more pointed towards the value-based care environment, you've probably already realized that you need these resources to move that needle, whether it's the removing the barriers of, I can't pay for my meds that we mentioned before, or this patient, has really severe mental health concerns, issues, needs, that if we don't address those, nothing will change about their healthcare either. So I think, and of course we know the impact of oral healthcare on a variety of different diseases. There is obvious value in prevention, at the forefront, but certainly depending on where you live and how you're insured, oftentimes patients don't have coverage for dental care, and they are receiving dental care in the emergency room, which is likely not to solve their issue. It's likely to cost a lot. And they're still going to land on the doorstep of somebody else to do the work. So skipping all those in-between steps of the not parts that will help them is really going to shift the way we, pay for this care and hopefully prevent these longer-term illnesses.
And the dental health, as I've gotten more involved with understanding the FQHC market, is something that is probably the biggest gap today between commercial and FQHC. And, totally makes sense, because even dental insurance, as we all know, doesn't pay for much. And there's very few people I know that haven't put off something from a dental perspective because it was going to be so much out of pocket, which, to your point, ultimately is going to lead to higher cost. And I have been to the emergency room for dental stuff in the past, and I can attest that no, it was not the best place to get the care. It was a very expensive visit just to be told to go to my dentist the next day, or a dentist.
Exactly. Yeah.
And we are recording this at the end of March. So we're seeing the light at the end of the tunnel, some positive nature from COVID and where we're at with that. But, if we look for a silver lining of any type, it really is brought to the forefront social determinants of health and behavioral health, and really bubbled that topic to the surface, which I think is going to be good for all of us as citizens of the country, individuals in our own health across the board. So little silver lining there.
Yeah, I agree. I mean, I think, quick little statement on that, as I know we're running out of time, is that, behavioral health and the workers and community health workers in the community health setting are really the rock stars, I like to call them, of telehealth, which obviously was a required emergent vector of care in the COVID world. And often it was those teams that were teaching our providers how to do that work because they were already experienced at it. And so I think they've led the way. We had an opportunity to do a lot more screening for some of those issues than perhaps we had always had on the floor in the past. So we built up, in certain cases, much more information. And now it's a question of, what do we do about it?
Excellent. Well, as always, time runs fast here. But thank you so much for joining us today, Heather. And thanks to our audience for tuning in. You can learn more about the show on the program's page of healthcarenowradio.com, and lend your voice to the conversation on Twitter at #voices in VBC, and be sure to follow Azara Healthcare on Twitter at Azara, AZARA DRVS, Azara Drives. I'm Matt Fusan, bringing you voices of value-based care you should hear. Until next time, have a great week.